Hello and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenauer, and today I'm joined by advanced heart failure cardiologist Dr. Jennifer Brown, Dr. Richa Gupta, and Dr. David Zhu, as well as cardiac surgeon Dr. Ezequiel Molina. Over 6 million adults in the United States are living with heart failure. In simple terms, heart failure means that the heart isn't pumping as well as it should be. This can result in fatigue and shortness of breath and significantly limit everyday activities such as walking or climbing stairs. While this is a serious condition, many people with heart failure can lead a full life when it is managed properly. It's important to understand the risk factors, symptoms, and all the treatment options available for heart failure. So if you'd like to learn more, then stick around, share this broadcast with your friends, and give us a like to let us know you're watching. And if you have any questions for our experts, please leave them in the comments below. Thank you all again for joining us today. Before we get started, could you all tell our viewers a little bit about yourself and the work you do? Dr. Brown, I'll start with you.
Right. Hello, everyone. Thank you for joining us. I am a heart failure cardiologist in Annapolis, Maryland, and I work out of Anne Arundel Medical Center, taking care of heart and trying to help people improve their quality of life and stay out of the hospital.
Great, thank you. Dr. Melina?
Thank you for joining us and thank you for the invitation today, Sarah and MedStar. It's great to be here. My name is Ezequiel Molina. I'm the surgical director of the heart transplant and the LVAD program at the Washington Hospital Center. And I obviously do heart surgery, and amongst the many different procedures that I do procedures for congestive heart failure, such as heart transplants and implantation of heart pumps that can help patients with advanced heart failure.
Thank you. Dr. Gupta?
Hi, everyone. Thanks for being here, and I'm excited to be here as well. I'm Dr. Gupta. I'm one of the advanced heart failure cardiologists here at Washington Hospital Center. So what that means is I take care of patients with general heart failure. I also take care of patients who are being worked up for a heart transplant or a heart pump or an LVAD, a left ventricular assist device. I also take care of patients after they've received a heart transplant or a heart pump. So kind of all along the spectrum of heart failure, I'm involved in their care.
Great, thank you. And Dr. Zhu?
Hi, thank you for having me. I'm Dr. David Zhu, and I am one of the heart failure doctors up here in Baltimore. I'm part of the MedStar system. I work closely with Dr. Gupta and Dr. Melina as well. We certainly send patients who need more help down in DC. But a lot of our patients are up here in Baltimore, so that's where I'm primarily based, taking care of our heart failure patients in Baltimore.
Great, thank you. Well, once again, thank you all for being here. We really appreciate you taking time out of your day to do this. So let's get into the questions. First of all, we kind of mentioned this a little bit in the introduction, but like I said, it was a brief description. So Dr. Brown, what does heart failure mean? What exactly is it?
So heart failure, I would call this an umbrella term, meaning it encompasses a lot of different types of dysfunction from the heart. But the general theme is that there is cardiac dysfunction that leads to fluid buildup in the lungs, often in the belly and the legs as well, that cause patients to be short of breath and fatigued. The cause of heart failure, really, there are many. The heart can be weak. The heart itself can be stiff. This happens often as people age, or if they have other processes that cause the ventricle and the muscle to stiffen. There can be arrhythmias that cause the heart to weaken. There can be valvular problems that cause the heart to weaken. Viruses can cause the heart to weaken. So it's really important that we understand the cause of heart failure so that we can help people recover.
Right, exactly. Thank you. And Dr. Molina, can you explain ejection fraction and the role it plays in heart failure?
Yeah, sure. So the heart is a complex pump that is composed by 4 chambers and 4 valves. So the right-sided chambers receive the blood from the body and send this blood to the lungs to get oxygenated. And the left-sided chambers of the heart receive the blood from the lungs, and there is a very important chamber called the left ventricle, obviously on the left side, that is the main pumping chamber of the heart that pushes that blood to the different organs and tissue so they can do the work that they are supposed to do. So the heart has, amongst many functions, two are very, very important. One of them is to relax, to accept the blood. And the other one is to contract so the blood can be ejected from the heart. So the concept of ejection fraction is is a number, is a percentage, and is a percentage of blood that leaves the heart with every contraction of the left ventricle. So when the left ventricle, which can be viewed in some tests as a circular chamber, contracts, it doesn't squeeze 100% of the blood that is inside. Typically, normally ejects about 60%. That is normal, okay? That is the normal ejection fraction of a normal patient. When some patients develop congestive heart failure, that number drops, meaning that the percentage of blood that leaves the heart with each contraction is less and less. And it can get very dangerously low, as of 10%. It is important to understand that this is just one of the parameters we use to assess heart failure and follow patients with heart failure and their response to treatment. We don't base all of our decisions just on this concept of ejection fraction. There are other things that are equally important, such as symptoms, other testing means that we have to assess the function of the heart. But the ejection fraction is one that is important, and I think every patient should try to remember what their ejection fraction is at a certain time on their journey with heart failure. Ejection fraction is not a number that remains equal throughout that journey. It can improve sometimes, although typically it just keeps getting worse on patients with advanced heart failure. There are many tests that can provide this number. More commonly, this number comes from an echocardiogram. Okay. But there are many other tests that can inform this number. CT scans, MRIs, nuclear tests, etc. It's also important to understand that not every patient who has heart failure has a decreased ejection fraction. There is a form of heart failure in which the heart actually still contracts well, but is unable to relax, is unable to receive the blood. And that's a form of heart failure with normal ejection fraction. Interestingly, this is more common in women than in men. Okay.
And you mentioned importance of knowing symptoms. So my next question is, Dr. Gupta, what are some of the telltale symptoms of heart failure that people should look out for?
Yeah, that's a great question. And I think it's an important question for patients to be just aware of. I like to think of the symptoms in kind of two categories. One is symptoms that result from having too much fluid buildup. And so just like Dr. Brown and Dr. Molina mentioned, fluid can build up either because the heart muscle is weak or because it has a relaxation problem and becomes too stiff. So there's, it can be multiple reasons. Some of the symptoms of fluid buildup might be worsening shortness of breath with activity, with walking, with exertion, difficulty with breathing, lying flat at night, kind of developing a new sort of cough at night with difficulty breathing is one sort of symptom. Increased swelling in the legs because of fluid buildup. Those are kind of some of the ones that I think are the most common for the ones that I see in my patients. Sometimes increased swelling in the belly as well. It doesn't always have to be in the legs. Okay. And then kind of the second category is a little bit when the symptoms become more severe, worsening fatigue, so feeling more tired with usual activity, loss of appetite, even nausea, or kind of just indigestion. Sometimes those can be signs of more advanced heart failure too.
Okay, thanks for letting us know. That's important stuff to look out for. And going along with that a little bit, Dr. Zhu, what are the most common risk factors associated with heart failure?
Yeah, there's a lot of different risk factors. I want to thank my colleagues for bringing up the two causes, broad categories of heart failure. Traditionally, we focused on patients who have the squeezing function issue, but more and more we're discovering patients who actually have the relaxation part. So some of the common things, I break it down in things that you can control and things that you cannot control. Things that you can't control are getting older, the genetics that you were born with, mom and dad. You can't pick those things. You can't pick other things, but something that you can control include high blood pressure. That's very important. So uncontrolled high blood pressure, uncontrolled diabetes, those are probably some of the most important things and more common risk factors for heart failure. Other things include toxins that you put into your body, smoking, alcohol, tobacco. So those are the most common risk factors that you have to worry about in terms of heart failure. Of course, there's a lot of varieties out there, and really each individual is different. So which is why talking to your doctor is very important and trying to figure out how to minimize those risk factors as much as possible.
Right, right. And Dr. Brown, my next question, I'll kind of, lump into two. We talked about symptoms, the risk factors. So what are some of the more, I guess, like urgent warning signs and, that might point you to saying like, okay, I need to go see a specialist right now to get a diagnosis and see what's up?
Absolutely. So I would say one of the biggest warning signs is rapid weight gain. So we say if you gain 3 pounds in a day or 5 pounds in a week, that is usually fluid. And particularly if that's accompanied by some of the symptoms that Dr. Gupta mentioned, like a cough when you're lying flat, or an inability to lie flat, or swelling in your ankles or in your belly, those are all signs that you need to seek medical attention right away. And what we see often in our patients is that when patients do not pay attention to those signs, the weight gain and the decompensation can really rapidly snowball and get to the point where hospitalization is required. And our goal is really always to try to get control of these symptoms with medicines and help people stay out of the hospital.
Okay, great, thank you. And so Dr. Gupta, how is heart failure diagnosed? After you go to your doctor, you realize, okay, I need to get checked out. How is it actually diagnosed?
Yeah, so typically kind of in an office setting, if I'm seeing a patient, physicians can diagnose heart failure mostly by symptoms and by the physical exam. So in a patient that has extra fluid, you can actually see that on exam. You'll see increased leg swelling. We actually look at kind of a dipstick on the neck, the jugular venous pressure. That's a fancy term for basically a fluid column that's directly that goes down to the heart that we can actually visualize on a patient's neck. And if we see that that's elevated, we know that there's something going on with the heart that's causing extra fluid to be on board. And then aside from sort of, symptoms, how the patient is doing, and their exam, we also look at imaging studies such as the one that Dr. Melina had mentioned. So an echocardiogram or other modalities like a cardiac MRI or a CT can also assess this to look at the pumping fraction to tell us if there's an issue with the pumping fraction or if this is more of an issue of relaxation. And then there's certain lab tests that we also look at, certain cardiac enzymes that can be elevated in heart failure specifically. And all of those together kind of help us as clinicians diagnose heart failure.
Okay, and I was going to be my next question is who diagnoses it? And maybe another part of that is where would you recommend starting out? If you do need to go see a doctor, would you go, to your primary care, go straight to a cardiologist? What would you suggest?
Yeah, I think it's completely reasonable to go to a primary care doctor and kind of let them know that this is something that you're worried about and thinking about. That way, the primary care doctor can also evaluate a lot of those things and make a referral to a cardiologist if some of those findings come back to be concerning. I think it's also okay to start with the cardiologist as well. It's sometimes heart failure can be more subtle than we think it is. And so it may take some additional testing and thinking to sort of tease it out, particularly I think in cases where the ejection fraction is not necessarily reduced. It can be a little bit tougher, but it may still be heart failure at the end of the day that's going on. So I think if any primary care physician, coming to them, if they are concerned, then they can make a referral to a cardiologist.
Right. Yeah, I've done a lot of these Facebook Lives, and that's always what they say is a good place to start if you're kind of in doubt is go to your primary care and they'll direct you to what you need to do next. And Dr. Hsu, can you explain the different stages of heart failure?
Yeah, thank you. So there's actually 4 stages, and usually we use these 4 stages to kind of describe where you are in the journey of heart failure between different doctors or different clinicians. So there's A, B, C, and D, A being the least severe and D being very severe. So A is when you have risk factors, going back to what we talked about earlier. So you don't have any changes in the heart yet, but maybe your family had heart failure or you have high blood pressure. So those are all risk factors, but it hasn't affected your heart yet. Stage B is a little bit more advanced. So now you're starting to see changes in the heart that's abnormal, but you haven't had the symptoms. Stage C is usually when people end up in a hospital or they have symptoms and they go to their doctor and say, something's off, I'm not breathing right, or they end up in the emergency department with a lot of swelling. And that's when you have the heart changes, such as a low ejection fraction, and then also the symptoms that go along with it. The great majority of our patients come to see us in stage C. And then stage D is when you're really in trouble. And that's when experts like Dr. Gupta and Dr. Molina really can help us, because the rest of the body is starting to suffer as well. The heart is so weak or in such trouble that, you're always in a hospital and the rest of your body just can't get enough blood flow, and you need something more than our traditional therapies, which are medications.
Okay.
Sarah, can I add something?
Of course, yeah.
Regarding the last 2 questions, when to see a cardiologist and the different stages, I have a very aggressive approach to this. I think a paradigm or cultural change has to happen. When you unfortunately develop cancer, you don't stay with a primary care physician taking care of your cancer. You go to see a cancer specialist. Unfortunately, when you develop advanced heart failure, many times you're not referred as a patient to an advanced heart failure specialist, as Dr. Brown, Dr. Gupta, and Dr. Su. And that is wrong. That is wrong. Many times we see patients that get referred to us when it's too late. When patients are not candidates anymore for an LVAD, which is a heart pump, or for a transplant, or for any other treatment. And unfortunately, many of those patients die because they're being referred too late. So I think if you're a patient with heart failure, particularly on the advanced stages, you have to request your doctors to be referred to an advanced heart failure specialist. These are very, very intelligent, smart people that have all the tools and all the knowledge to manage your disease. But unfortunately, and without any disrespect to the other specialties, they might not have that knowledge and those tools. So I think something has to change. We see over and over patients being sent to us when it's too late, and that should not be happening.
Right. Thank you for that. I think that's a very good point to make. And I'm just going to take a minute to pause and say, if you're just now joining us, thank you for tuning in. Today, I'm joined by advanced heart failure cardiologist, Dr. Jennifer Brown, Dr. Richa Gupta, and Dr. David Shu, as well as cardiac surgeon, Dr. Ezequiel Molina. And we're discussing heart failure. While this is a serious condition, many people with heart failure can lead a full life when it's managed properly. So it's important to understand the risk factors, symptoms, and all the treatment options available for heart failure. We've got a lot more to talk about, so stick around, share this broadcast with your friends, give us a like to let us know you're watching, and if you have any questions for our experts, please ask them in the comments below, and we will answer those during our discussion. So back into the questions. Speaking of treatments for heart failure, Dr. Shu, you mentioned what are some of the most common medicines used to treat heart failure, and what do they do?
Yeah, thank you. So like Dr. Melina said, there's a lot of tools now available for us, and early recognition is key because we want to be able to apply these tools, and sometimes it can be overwhelming. There's so many medications out there. Research is ongoing to stay ahead of the field. There's now a lot of focus on patients who have heart muscle weakness, and there's 4 pillars of medication that we use. And this has been researched over many, many decades. No doubt you've seen commercials on TV for them too. So one of the most common medications that we use is a beta blocker. And there's different types of beta blockers that we can use depending on each individual patient. Another pillar of medication falls under medications such as lisinopril, losartan, and then the newest one, which is Entresto. All three of those medications fall under a certain type of drugs. So you would just pick one of those medications, depending again on how you're doing. Another medication that we use commonly is called spironolactone. And then lastly, we're very excited to see medication that come out recently. Initially, it was used for patients with diabetes, but a lot of people with diabetes, again, also have heart problems. And we've seen that even with just heart problem and no diabetes, it's really helping patients. And that falls under the category of SGLT2 inhibitors. So it's a big mouthful, but again, so we have 4 pillars, and we have really good evidence in helping patients with weak heart muscles when they are treated with a maximum amount of those medications.
Okay, and so is there other non-medical ways to treat heart failure or take place of the medication?
Yeah, that's another really good question. So a lot of my patients, especially my younger patients, when they first get diagnosed, it's a little bit of a difficult disease to process because they otherwise feel good, but now you're telling them they have a very serious medical condition. So a lot of times they ask me, once my heart gets better, can I come off of these medication? And 2, are there any other non-medicinal ways of treating it? So I tell my patients that it's very important that they stay on these medications because they're doing their job once your heart is improved. But then one of the most important non-medicinal ways of improving their overall health is it's counterintuitive, but to watch their salt intake and then also watch their fluid intake. Oftentimes you see patients, TV commercials of, staying hydrated, make sure you get your water in. But our patients with heart failure, they oftentimes have trouble maintaining a balance in fluid, and they're usually on the other end, they're overly hydrated, and more fluid actually is more detrimental to their health. So a non-medicinal way of treating heart failure, so to speak, would be to limit the salt intake and then also be on a fluid restriction.
Okay, thank you. And that actually, we had a question from one of our viewers who said, my EF went from 35 to 60%. Will I be able to get off or stop medication? Kind of sounds like no, because like you said, they're helping. So you want to stick with it if it's working.
I will add to that, the most important thing is to keep talking to your doctor because everybody's individual case is different.
Right.
But for the great majority, we would recommend that they stay on their medications.
Right. Thank you.
Can I add something?
Yeah, of course.
Just in terms of another non-medicinal management of heart failure, I'm sure you all have heard of the mantra, know your numbers. And I think it's just really important that your numbers are well controlled. So for example, blood pressure needs to be well controlled. BMI needs to be well controlled, maintain a healthy weight. So there's certainly a correlation between obesity and many of the comorbidities that we're discussing, including heart failure and diabetes. So in addition to watching sodium and fluid intake, making sure that we're eating a heart healthy diet, that we're living a heart healthy lifestyle and exercising, all of these things can really help your heart failure. And additionally, this may also be counterintuitive, but managing your other comorbidities. So if you're a diabetic, for example, uncontrolled diabetes is strongly linked to uncontrolled heart failure and will increase that snowball and likelihood of readmission to the hospital. So it's not just enough to watch your salt and water intake and take your medicines, but you have to make sure all of your other disease processes are well managed. And along with knowing your numbers, your A1C is a very important number that needs to be well controlled.
Right. Thank you. And Dr. Brown, my next question is for you. Can both internal medicine physicians and cardiologists treat heart failure? Or if not, we kind of touched on this earlier, but when should you seek out a specialist and what type of specialist?
Sure. I think it's a really important question, and it's worth revisiting again for people that may have just joined the broadcast. certainly, if you don't have a cardiologist or know a specialist, starting with your primary doctor is a reasonable place to start. But I agree with my colleagues that every patient with heart failure definitely should be seen by a cardiologist and then transition to an advanced heart failure specialist when the disease process becomes more advanced. Some signs that the heart failure might be progressing. I think the biggest is probably frequent hospitalizations. If you're hospitalized multiple times for heart failure, particularly if you've had worsening, what we call end organ function. So for example, your kidney function numbers are getting worse or your liver enzymes are getting worse. These are all reasons to ask your cardiologist to refer you to an advanced heart failure specialist. And if your symptoms are uncontrolled. So we have really, really good medications now for heart failure. It's actually a really exciting time. We're helping a lot of patients get better. But some of these medications are new, and I don't know if all providers, both internal medicine, general cardiologists, are as familiar with all the data, are as comfortable prescribing everything, and sometimes just seeing an advanced heart failure specialist for a consult to make sure that you're on all the appropriate medications, or maybe they can be up titrated or a different diuretic can be tried. So these are all reasons to seek out more specialized care.
Right, exactly. And how often does a patient normally need to see their cardiologist to ensure their heart failure is under control? Is there, like an average number, or does it just depend case to case based on, each person?
Right. So heart failure is an extremely individualized disease process. So there is no particular answer for that question. It depends on the stability of the heart failure. I would say that our most stable patients who have what I would call either class 1 or class 2 symptoms, which meaning just very mild, they're not hospitalized, they just have a little bit of shortness of breath. Those are patients we can see maybe every 6 months, as long as they're on good medications and they're optimized and their numbers are where we want them to be. But for patients that are more advanced, class 3, where they have symptoms with minimal exertion, for example, those are patients we're going to see more often, maybe every 2 to 3 months, or maybe even more frequently if their symptoms are uncontrolled. And then once we get to our class 4 patients, our patients that have symptoms at rest, these are patients that sometimes we're seeing weekly, depending on how severe their illness is. So, the great news is now with telehealth, it has become easier to see your doctor more frequently if needed. I know that especially for our geriatric patients, are going down and people are seeking care, but telehealth has really allowed us to see our patients more frequently if needed.
Right, exactly. Yeah, that's a good point. And, going along with that, talking about symptoms, heart failure not being very well controlled, Dr. Melina, what are some of those signs that it's not well controlled and that increased treatment might be necessary?
I think Dr. Brown just described the main aspects of what uncontrolled heart failure looks like. And I totally agree that frequent hospitalizations is probably number one. If you get readmitted to the hospital over and over again with heart failure, that means that the heart failure is progressing very quickly, and you may need what we call advanced therapies. Dr. Brown also mentioned symptoms and water retention, etc. So once you develop advanced heart failure or stage D heart failure, it's important to know that this stage of the disease is very, very dangerous. When patients are on a stage D heart failure, this condition is as deadly as some of the deadliest cancers. It's as deadly as having lung cancer, pancreatic cancer. That means that you may have a chance of just 10% of being alive a year after the diagnosis. So it is extremely important to not to lose that window. When you reach that stage, important decisions have to be made. Otherwise, you could lose your window for advanced therapies. You could be admitted to the hospital in shock with kidneys that are failing, a liver that is in shock, and then you're not a candidate for anything else, just because anything else you can try, it's just not going to work.
And on the heart failure spectrum, when would surgery when is that recommended for a heart failure patient, Dr. Molina?
Right. So Dr. Su explained very well the different stages, A through D. So A, when you have risk factors, but you do not have heart failure. B, when you have changes in your heart, but no symptoms. C, when you start having symptoms. And then D is the advanced stages. So typically surgical therapies are implemented in stage D. Sometimes earlier on, for example, it's very common for patients to have coronary artery disease, having blockages and having an ejection fraction, as we spoke at the beginning of the talk, that is lower than normal. So for example, coronary bypass surgery might be indicated on those patients early on. Or if you have a valvular problem that is causing heart failure, fixing that valve can help you too. But traditionally speaking, specific surgeries for heart failure are implemented at the very late stages of the disease, when you develop stage D. Most of those patients typically belong to one or two categories. Either you are at home on a medication that is run on an IV called an inotrope, that is making you feel better, that is going to work for several months, but perhaps no more than a year or so, or you're very sick in shock, admitted to the hospital. So you're going to belong to one of those two categories. And the therapies that we have available at that stage are two big groups. One of them is heart transplantation, and there is a lot going on in that field right now. Things are very, very exciting. Or if you're not a candidate for heart transplantation, then we typically evaluate patients for a left ventricular assist device, which is a heart pump. Just to make it simple for patients to understand what each one of these therapies mean. If you live on inotropes, you might have a 50-50 chance of being alive at a year or so. Okay, so the survival is not very good just on those inotropes. If you get an LVAD, that 50-50 chance is 5 years. But if you get a heart transplant, that 50-50 chance goes up to 13 years. That's what it means in terms of survival, each one of these therapies that we have available for patients on a stage D heart failure. Okay. And I'm sure some of my colleagues want to elaborate more on this.
I would say, does anybody else have anything they'd like to add on to that?
No, I completely agree with everything that you just said.
You summed it up perfectly. And so you talked about LVADs. Can you talk a little bit more about them? You know, how do they work? At what point do people need one? And sure. Just, talk about those a little bit more.
So LVAD therapy has been around for decades. Unfortunately, the first prototypes that were invented in 1960s and 70s were very bulky pumps with many moving parts, pumps that were prone to clot formation on the inside. So they were sporadically used in some patients, but the results were not good. Simply patients would just die from complications of that old pump technology. It wasn't until the early 2000s when we started having better pumps. However, the pumps that we had 20 years ago were still very large. The surgical procedure to implant these pumps was very complex, very invasive. And steel pumps have many moving parts, valves, and they just stopped working a few months after implantation. So we were successful in implanting the pumps, making patients feel better, improving the symptoms, but unfortunately, the durability of the pumps was just not good. It wasn't until something called continuous flow physiology was invented. Clearly, we all know that the pump works by pumping, right? There is a wave. The heart squeezes the blood. There is a pressure wave. The pressure goes up, so there is blood coming out of the heart, and then the heart relaxes. Pumps initially try to mimic the function of the heart, being pulsatile, having a pulse. But in the 2000s, a new technology came up that is called continuous flow physiology. In this new way of designing pumps, the paradigm changed. Instead of having a pulse, pumps would just eject blood in a continuous fashion, just like opening the faucet. The same way we open the faucet and we see the water drop, this is what current modern pumps do. They just propulse blood in a continuous fashion. These pumps are much more durable. So these pumps now can last 5-10 years, even more if patients didn't develop other complications. So these pumps have revolutionized the treatment of heart failure. And this is why now approximately 4,000 of these pumps are implanted every year in the United States. And as I said, the durability of these pumps on average is about 5 years. Obviously, the journey with one of these pumps is not perfect. These pumps still have complications. Patients can have strokes, they can have infections, they can have bleeding through the GI tract. But overall, most patients feel really well. They're able to do again those activities that they did when they didn't have heart failure, and many of them, most of them, are able to carry a pretty normal life. Historically, we use these pumps to bridge patients to transplantation because we know that transplantation gives you a better survival. However, over the recent years, the allocation system for heart transplantation has changed, and now it's easier to get a transplant when you present very sick to the hospital. So the field has changed, and now we're pretty much using 90% of the pumps that we implant for patients who are not candidates for transplantation. And we are performing in the country also around 3,500 to 4,000 transplants a year. So about 8,000 patients benefit from these technologies, these procedures every year in the United States. It's important to know that the group of patients that could potentially benefit from these technologies is much, much larger, actually. It's probably 75,000 patients. So there are many, many patients that are still not being helped. This is why it's important, all the new technologies like that we have and we will have available. It is important to mention the recent very, very important step forward in xenotransplantation, where at the University of Maryland, a patient received a big heart because he was not a candidate for a transplant or an LVAD. Hopefully in the future, those technologies, those new procedures will help us to eliminate that gap between the 8,000 patients that are getting therapy and maybe the 75,000 patients that could benefit from them.
Right, exactly. Thank you for explaining that. And so my next question kind of goes along with what you've talked about, as well as we have a question from one of our viewers. So it's at what point is heart transplant indicated as a treatment for a patient, which you've touched on a bit. And then Harold asks, is there any information for patients post-transplant and possible long-term effects that they might have? Do you want to take that, Dr. Molina?
Living with a transplant, obviously, is not perfect. Transplantation, again, is the best therapy for heart failure. It's a definite therapy, but you have to take a number of medications to avoid rejection, and those medications can have side effects. So patients who receive a transplant have a higher chance of developing infection, developing certain types of cancer. And this is why the durability of a transplant is only on average 13 years and not forever.
Thank you, and for answering that, and thank you for your question, Harold. We have a couple more questions from our viewers that I'm going to go through. Kathy asks, what is the opinion of ECMP therapy? If you guys want to talk about what that is and your opinions on it. I'll say whoever wants to take it can go ahead.
Yeah, I think I'll take that question. So I think they're talking about extracorporeal counterpulsation, which is a older technique that we've used in the past, not so much for heart failure, but for patients with refractory blood flow issues to the heart muscle. So it's not something that we usually do when patients have very, very advanced heart failure. We still stick to the therapies that Dr. Molina talked about for LVAD implantation and transplant. And then before that, we obviously use these medications that we talked about to prevent the progression of heart disease. And of course, if possible, the bypass surgery that Dr. Melina also performs.
Okay, great. Thank you for explaining that. Our next question is from Dave. He asks if you have been diagnosed with, and I'm going to try not to butcher this, xanthelasma. Would you say you would need to be tested for possible heart failure?
I can take that one too, I guess. Or Dr. Gupta, you want to take that? No? Okay.
Either of us, you join in if you have anything else.
Yeah, please fill in any gaps. So xanthelasmas are kind of like cholesterol plaques that you can see on the skin. Typically, you can see them on eyelids or on tendons, especially the Achilles tendons. That's actually a pretty big signal that you may have something called familial hypercholesterolemia, where your cholesterol level is sky high, and you should really see if there's a family predilection, other people in your family also having it. You should get tested for this condition. And it's fair, I think it's underdiagnosed, but we have also good treatments, again, not specific to heart failure, but targeted to the high cholesterol itself. So there's definitely medications out there that can help reduce cholesterol in your bloodstream so that we can prevent heart issues down the road.
Yeah, it's definitely a sign that you should get your blood pressure, your cholesterol levels checked, just to see where they're at.
Okay, thank you. Next question is from Kevin, who said he had a double bypass this past January. His pain has been amazingly low, but he finds himself still taking a lot more naps. Is this common, a common, side effect or something that could happen afterwards?
Yes, absolutely common, particularly if surgery was so recent. It is important to understand that some of the therapies we have are incredibly invasive for the body. So you cannot expect to feel normal right away after any of these procedures. And every time we open the chest through the front, called a sternotomy, either for a transplant, an LVAD, or coronary bypass surgery, typically the body will demonstrate signs of that invasive procedure for some time, and typically takes at least 3 months, and in some patients even more, 6 months or more, to fully recover after these operations.
Okay, thank you. Thank you for your question. Next one's from Norma. She's wondering, what about heart palpitations? Can this affect, is this possibly a sign of heart failure or something else? Dr. Brown, did you want to take this one?
Sure. I also wanted to just comment, I was on mute, sorry, about the last question briefly. Another plug for non-medicinal approaches to managing heart failure or post-surgical treatment is cardiac rehab. So as Dr. Molina said, it is very common post-surgery to be tired and for the body to take time to recover. And in fact, that's not just after surgery, even after a hospitalization, the body deconditions very rapidly. It's said that every day spent in the hospital can take a week to regain stamina. So for our heart failure patients and for our patients that are post-operative and post-stenting to the heart or valvular repair, we can offer them cardiac rehab, which is a really wonderful resource for our patients to work with exercise physiologists being monitored, on a telemetry unit, so we can make sure that their heart rate and blood pressure is stable while they exercise and make sure they're safe, but also give them the skills they need to regain their strength and stamina. And I'm sorry, so back to the other question, would you mind repeating it again?
Talking about heart palpitations, if those, could be
Sure.
a sign of heart failure or something else.
Sure. Yeah, heart palpitations should definitely be evaluated. If it is something that is occurring intermittently and it's not so debilitating, it's probably unlikely going to cause heart failure. There are many different types of palpitations. There are benign palpitations versus pathologic palpitations. And again, all should be treated even if they're not pathologic, because symptomatically patients will feel much better if they're not experiencing those palpitations. But pathologic palpitations, there are several arrhythmias that can cause the heart to weaken if they're uncontrolled. So you may have heard of atrial fibrillation or atrial flutter. A lot of our patients with heart failure also have these arrhythmias. Sometimes these arrhythmias can be the cause of heart failure, in that if the heart is the rate is very rapid and uncontrolled, it can lead the heart to get weak over time. And so actually getting the heart back into a normal rhythm can reverse heart failure for those patients. Other times, patients have both concomitantly, but fluid overload stretches the heart and can cause worsening arrhythmias and AFib. So sometimes it can be chicken or egg, but it's really important to work with your cardiologist on getting to the bottom. And the last thing I'll say is, there are arrhythmias that are severely pathologic that can be fatal. So ventricular tachycardia, for example, and this we commonly see, unfortunately, in our advanced heart failure patients. And it can be a cause of sudden cardiac death. And it's actually a reason why we put defibrillators in our patients with severe weak hearts or systolic dysfunction. So absolutely, palpitations need to be evaluated, and they can be a symptom of heart failure. They often are not, but they can be.
All right, thank you for explaining that, and thank you for your question. I have a few questions related to COVID and heart failure. I know I've seen some stuff, linking the two a bit. So I was wondering, do heart failure patients have a higher likelihood of contracting COVID-19, or do they have a higher risk of, complications if they do contract COVID? Dr. Brown, did you want to answer that?
There's no question that patients with heart failure or coronary disease or hypertension in general are at higher risk of having more severe infections with COVID. So absolutely, everybody should be vigilant about making sure they're vaccinated and boosted, wearing masks when you're indoors and with other people, and making sure that you're doing a lot of hand washing when you're around other people to try to avoid getting COVID. But particularly our heart failure patients need to be very mindful. And we've spoken a lot today about our transplant patients. We certainly have concerns about our transplant patients getting immunity from vaccines and from the boosters. So those patients in particular need to be very, very careful about spending time and being safe.
Right. And then for patients with no previous heart disease or heart failure history, can COVID possibly cause heart failure? Have you seen any of that?
Yeah, so I'll start. I'm sure my colleagues want to chime in, but we have definitely seen cases of what we call myocarditis from COVID, which is inflammation of the heart that can cause the heart to be weak. It can cause patients to be very, very sick. And it is certainly a life-threatening complication from COVID. And we are very concerned about that. And again, it's just a reason why we all need to be vaccinated. But I'll turn it over to my colleagues who I'm sure want to add something.
Yeah, there have been two issues that have generated controversy in the news and in general discussions. One of them is the issue of myocarditis, as Dr. Brown just referred to, and the fear that receiving a vaccine can have effects on the heart and cause myocarditis and make receptors of the vaccine really sick. And the studies, I think, have been pretty clear, showing that even when it's true that vaccines very, very sporadically can cause myocarditis, in general, those cases are very mild, and it's extremely, extremely, extremely unlikely to have a serious event because of myocarditis secondary to a vaccine. It's much more common to get myocarditis because of COVID, and it's much more serious, the myocarditis that COVID causes. So I think that should be should be said very clearly to the population to eliminate this irrational fear of the vaccine. The other controversial topic has been transplant programs, requesting that prospective candidates for transplantation receive the vaccine prior to transplantation and not considering patients who refuse to get the vaccine for transplantation. And once again, the data that we know, the studies that have been done show that if you are a transplant patient and you suffer COVID, your mortality risk is high, is very high. These studies have shown a mortality risk of 15 to 30%, which is very, very, very high. And also, if you get a transplant and get immunosuppressed because of medications you have to take to prevent rejection, then you're not going to respond to the vaccine very well. So it's important to receive the vaccine before you get the immunosuppression, so your immune system is ready to fight COVID if you develop the disease after transplantation.
Right, thank you. And then one more COVID-related question. You hear a lot about long-term effects of COVID, and can you talk about those from a cardiovascular perspective? If there is lasting effects, will they eventually go away? Is there, treatment or things you can do to help them go away, or is it, you know, a lot of times permanent damage?
I can try to take this one. I think there's a lot about long COVID that we still don't understand, and we're still learning about. I don't know that there are any specific treatments for long COVID that anyone is aware of right now. In terms of effects on the heart, actually, there's some thought that some long COVID may be sort of residual inflammation in the body, which might affect the heart as well. So Dr. Brown had mentioned myocarditis as one of the effects of COVID infection itself, where the heart becomes inflamed. And, you know, it's possible that that inflammation just takes a long time to resolve in general, and that is what makes people feel poorly.
And I also want to add, I've seen many patients with long COVID that have palpitations and tachycardia. And physiologically, we don't totally understand that tachycardia because the patients, for example, you do lung studies and they're okay, and you do the echo and it's okay, and even their cardiac MRI looks okay, but they're walking around tachycardic. And we've seen this in a fair number of COVID patients. So there are symptoms for the tachycardia. I'm sorry, there are treatments for the tachycardia. So we can give patients medications, which we've already discussed, called beta blockers, to help kind of suppress those feelings, because it doesn't feel good to walk around with a heart rate of 120. But as in terms of how long it will last, we're still collecting the data and we just don't have enough information. And certainly a lot of patients with long COVID can have fatigue and decreased stamina that can take a very long time to recover. But again, I think this is where our cardiac rehab and pulmonary rehab come into play, and exercise and regaining stamina is very important.
Right, right. Well, thank you. Yeah, like I said, you know, we've been hearing a lot about COVID relating to heart related issues. So I thought it was a good, you know, important to address some of these questions. But my last question for you guys is if there's anything else important that you'd like our audience to know about heart failure that we didn't touch on, or, you know, just what message you want them to take away after joining us and watching this broadcast. Dr. Chu, I'll start with you.
First of all, I'd like to thank you guys for having me. This has been a pleasure. I think the take-home message, if we can leave with one thing, is heart failure is a very wide range, and individualized care is very important. And I think earlier referral is the most important thing. Even if it's just one visit once a year, let us take a look at you, make sure we're on the right track and we're not missing anything. Because like Dr. Brown said, a lot of different things can cause heart failure. Thank you.
Right, thank you. Dr. Molina?
I would like to thank you and MedStar for the invitation as well, and for all the participants that asked very interesting questions. I would say to patients who are suffering from heart failure that you don't have to die of heart failure. We right now in 2022, we have so many different tools, strategies, treatments, drugs to treat the disease that you don't have to die of heart failure. Please do not give up on this disease, even if it's advanced. But as David just mentioned, it's important to get referred to the right specialist at the right time to avoid being referred too late when nothing can be done.
Right, exactly. Thank you. Dr. Gupta?
Yeah, I think my sort of take-home message echoes a lot of what has just been said and what Dr. Molina just said. You know, the point that heart failure really is treatable. And I think it's really important for patients who have heart failure to understand that good quality of life is possible, both at early stages and at late stages of the disease. You know, there are options. So again, it's important that, you know, patients with heart failure are seeing a heart failure specialist, so that all of those treatments are being considered fully, and our options on the table. In the early stages, you know, we have good guideline directed medical therapies, meaning a lot of the medications that Dr. Zhu mentioned, which can actually reverse and improve heart failure or keep things stable for many, many years. And a heart failure cardiologist can also dig a little deeper into understanding the etiology of the heart failure to see if there's anything else that's reversible or treatable about the cause of heart failure that we could target. And then at the late stages, as Dr. Molina just said, we work patients up for potentially heart transplant or for a heart pump if we feel that the time is needed for that.
Great, thank you. Dr. Brown, you have the tough spot of going last after everyone's already made their good points, but do you have anything to add?
Yeah, I do. Thank you so much again for having me and for all the participants. I completely agree with everything my colleagues have said. And I will just sort of take the other end of the spectrum to say, if you're a young person watching and you're thinking, oh, I don't have any of these problems, this is great. I would just say that many of the causes of heart failure are preventable. And we know that coronary disease starts as young as your 20s and 30s. So making sure that from a young age, you're managing your blood pressure, your cholesterol is well controlled, you're exercising, you're maintaining a heart healthy diet, all these things to prevent the development of uncontrolled hypertension, diabetes, coronary disease, because all of these things down the road lead to heart failure. And once you develop heart failure, I agree, our medicines are wonderful and we can often improve or at least prevent the progression of the heart failure for many years. And our treatments at the end stages are so much better as well. So the prognosis, it's really, it's much better to be a heart failure patient now than it was several years ago. There's no question about that. But my takeaway point would be that what you do every day matters, how you treat your body, what you put in your body, all of that really matters and can help improve your risk of developing heart failure in the future.
Right, exactly. Yeah, that's, like you said, we have treatment and everything that you can help to manage it, but the best thing to do is just prevent it. Do things you can to prevent it. So great. Thank you guys all so much. That wraps up our broadcast. Thank you again for joining us today, our viewers, for tuning in and asking your questions. If you would like more information, you can visit our heart and vascular page on our website, which we will be posting a link to in the comments below. Thanks again for joining. Have a happy and healthy Heart Month, and we will see you next time.